Thank you. I apologize for the technical difficulties, guys. So I'm going to start, and hopefully, if this will work. So, thank you for allowing me to be part of your program this morning. My name is Tim Bunchman, and if you notice the title says Nephrology and Rheumatology, we are a blended program. So it's like a European model. Can you go to the next slide, please?
Hold on one second. I'm going to stop sharing for a second because I need to pull it up a different way. There we go.
At one point in time, I was seeing this slide. Can you go to the next slide, please?
Sure, 1 second.
Thank you. This is who our group is. And many of you I've talked to at times. We cover rheumatology often on the weekends. So Sarah Hoffman and Drew Long's joining us soon. This is our group. That's my cell phone. And I put it out very specifically because I'm very comfortable with people calling me. We deal with a lot of phone calls, and we don't always have to see patients, but that's my cell phone. Next slide, please. So let's talk about renal disease. Next slide, please. So the first part of this, we'll be talking about nephrotic syndrome. And we know what these children look like. They look puffy. It's interesting to me that often will happen, a diagnosis of childhood nephrotic syndrome will be misidentified for a few weeks because most of these children will wake up in the morning with puffy eyes, and the heaviest part of the body is the head. But as the day goes on, the edema goes to the feet. So by the time they get seen, and often these are 2 or 3 year olds, there's no facial edema. So they get misdiagnosed as either having allergic reaction or a sinus disease. And getting a urinalysis from a 2 or 3 year old, sometimes like getting Congress to get along. Next slide. So the triad, which is edema, in adults is greater than 3 grams. In children, it's 40 milligrams per meter squared per hour, but it's a lot easier to say 3 grams. Albumin, by definition, less than 2.5, and elevated triglycerides and cholesterol. Within the subset of classic nephrotic syndrome, 15% of children will have hypertension and 25% will have microscopic hematuria. And this is why the literature is so messy that cross-reference nephrotic syndrome and glomerulonephritis. Next slide, please. So nephrotic syndrome is divided up by age groups. 0 to 3 months, by definition, is called congenital nephrotic syndrome. 3 to 12 months is either called infantile nephrotic syndrome. The classic nephrotic syndrome that we all used to seeing is the kids between 1 and 12 and greater than 12 years of age, or glomerulonephritis type of workup. It's interesting that the congenital nephrotics often show up with an abnormal TSH screen because they have no TBG or thyroid binding globulin. Therefore, their TSH screen becomes abnormal. The children with the infantile nephrotic syndrome are either having genetic causes like Denay-Drash syndrome or Biot-Burdett syndrome, or infectious causes such as vertical transmission of disease such as HIV or hepatitis. Next slide, please. The standard evaluation is always there. I'm a big believer in let's start at the beginning. What is the blood pressure? What's the exam? I also like to ask parents what they know their previous weight of their child was. It gives you a better sense of what's going on with them and how much fluid weight they've been on. House staff here know that every day when I ask for rounds, I want to know what the weight and the blood pressure of the exam is. I don't want to know about lab work. I'm an old-fashioned clinician. Lab work is important. The classic CBC, the BNP. Remember, the BNP does not have an albumin, so you need to have an albumin. We always do complements initially. We'll talk about that later on. We do a cholesterol panel. In the old days, we'd have the kids pee in a bucket for 24 hours and do a 24-hour urine collection. Now you can just do a spot urine to send to lab for protein creatinine ratio. Next slide. So in classic childhood nephrotic syndrome, it's a relatively straightforward. If the child does not have renal insufficiency, if the child is making urine, essentially we start the kids on steroids. There's this debate that will go on forever, whether they should have a PPD first or not. Sodium restriction is critical. Sodium loading makes the edema worse. And often we do not encourage the use of ACEs or ARBs at the very beginning because it can change the blood flow. Remember that ACEs and ARBs vasodilate the efferent arteriole out of the glomeruli. And if nephrotics are intravascular volume depleted, you actually can precipitate renal failure by that combination. So we usually did not recommend those up front. Next slide, please. The mechanism, the edema, is kind of a combination of everything. There's urinary sodium retention, the serum albumin drops. It affects the whole renin-angiotensin system. And then that gets to the whole discussion is, do you get rid of the albumin? And the question is, do you do albumin infusions, and what are the complications? Well, we do albumin infusions on children who have oliguria that are having any sort of respiratory symptomatology. In the United States, albumin comes in a 5% and a 25% concentration. I say that because in Australia, there's 4% concentration. And the way to think about these, the 5% concentration is 5 grams per 100, and 25% is 25 grams per 100. So if you've got a child who's a liter of fluid overload, but all the volume is extravascular, we often will use, if you will, the thick albumin, the 25% albumin, given very slowly, usually followed by a loop diuretic, to actually help bring extravascular to intravascular. It does have some risk of complications, and Lord knows I've seen enough of those. If the fluid goes from the extravascular to intravascular at a rate that exceeds the diuresis, then that causes malignant hypertension and pulmonary edema. So be prepared to look for complications of that and go slow. There's usually no rush to do this. Next slide, please. If one biopsies these kids, classically the glomeruli is normal. This is a typical glomeruli of a child who's got a normal looking kidney. Bear with me with my experience. We do a number of biopsies, 40, 50, 60 biopsies a year. We're very fortunate here. We have an incredibly good pathologist, so we can actually biopsy someone and look at tissue the next day. Next slide. This is a scanning EM, and those of you who fell asleep during medical school, and remember this is the basement membrane. There's there in the middle. The towers on the outside, that's on the urinary space. Those are the podocytes, and the flat stuff on the inside are endothelial cells. That's a normal looking EM. Next slide, please. If you look though at this one on the outside, and I wish I had a pointer, I apologize if you do not. The outside, the podocytes are flattened. So one of the classic abnormalities seen on electron microscopy in nephrotic syndrome is flattened podocytes, or what's called podocyte effacement. It doesn't really mean much. It's just that they just make pretty pictures. Next slide. So the vast majority of childhood nephrotic syndrome grow out of this. They typically grow out of it after puberty. And if you look at children who have steroid responsive nephrotic syndrome, which is 80 to 90% of these children, if you biopsy them, 80% are minimal change, but 20% are focal sclerosis. Those children who do not respond to steroids are classically in trouble. And we'll pick up 1 or 2 kids like that a year. We see about 14 to 18 new nephrotics here a year, just to give you some numbers. And steroid resistance portends to a poor prognosis, where 70% of children who do not respond to steroids, and the definition of steroid responsiveness is having the urinary protein negative, usually by day 21. But if they do not respond to steroids and they go on to end-stage renal disease, which 70% do, and if we transplant them, which we do, there's an 80% risk of recurrence rate in the first 4 hours after transplant. So we really are not happy when we see a steroid responsive patient, because not only do they have short-term complications, but they have long-term complications, which we have to be careful about. Other biopsies that you'll see besides minimal change is focal sclerosis, and you'll see that more commonly in the steroid resistant, except the last 2 kids we've transplanted who have steroid resistant nephrotic syndrome have minimal change in their biopsy. So the biopsy does not 100% correlate with the risk of going on to end-stage renal disease. And then there's other causes such as membranoproliferative membranous, which we'll talk about under the glomerulonephritis section here. But essentially, we biopsy patients who are not responding to steroids. We biopsy patients who are looking at other modalities of care, such as tacro, cyclosporin, rituximab, cyclophosphamide. So we want to have some baseline data so we know where they're looking at. Next slide, please. So what kills nephrotics are these two. They're basically infection and clotting. I tell the people the story when I was a fellow in Minnesota back in the 80s. Yes, I am old. Thank you very much. I saw a young lady on Friday afternoon with my attending. I was a third year fellow at the time, and I was worried she had sinusitis. This was the known nephrotic. She was in a full flare. We debated whether to put the child on antibiotics or not. We did not. The next day, this was February in Minnesota. Those of you who've ever been to Minnesota, sometimes in February, the high for the day is 20 below. But she went to the Ice Palace the next day, which was an outdoor 3-story ice palace, looked like a Cinderella's castle. And the next day she was dead from pneumococcus. And this is exactly what happens with these children. They cannot opsonize bacteria. They get encapsulated organisms. They develop either H. flu, pneumococcus, or strep. And it's just devastating. It's absolutely devastating. The other thing they do is they have clotting, and they actually lose antithrombin 3. And on top of that, if you've got a low albumin, you've got a low oncotic pressure, you're hemoconcentrated. So the combination of loss of antithrombin 3 and hemoconcentration portends toward a high risk of clotting. And I've seen one child in my life in a hospital without any sort of IVs in, through a PE, and just died right in the hospital. So it does happen. One of our most recent membranous nephropathy patients clotted off both her kidneys, which we've now recovered with the use of antithrombotics. But it does happen. So these things are devastating when you see them. Next slide, please. So I'm going to go right to glomerulonephritis. This was me as a newborn. Next slide, please. So nephrotic syndrome presents with edema, and glomerulonephritis presents with edema, but glomerulonephritis is often associated with bloody urine. Now remember that 25% of patients with nephrotic syndrome can have microscopic hematuria, but they classically do not have grossly bloody urine. So their presentation is overlapping a bit, but at the same time, the bloody urine is distinctly unique to glomerulonephritis. Next slide, please. So I have a partner, Megan Lowe, who's absolutely fantastic, and she's a good nephrologist, which I'm not. She will take a urine, spin it down, and look for this, which is called a red cell cast. So going back to nephrotic syndrome, the diagnosis of nephrotic syndrome is the quadrad of protein greater than 3 grams, albumin less than 2.5, elevated lipids, and edema. But the diagnosis of glomerulonephritis is based on this finding alone, which is the red cell cast. So again, the presentation may be overlapping, but the diagnosis is quite different at the same time. Next slide, please. Those of you who are beer aficionados, and I'm more of a wine drinker, this was put together by a friend of mine. A fantastic slide, by the way. So if you don't want your urine to look like Guinness, that's a bad glomerulonephritis, then you need to think about what is the texture of the urine. And the parents will come in with pictures of the urine and all sorts of stuff, which is really interesting, but gross at the same time. Next slide, please. So glomerulonephritis patients are really quite different. The last hypocomplimentemic or post-infectious glomerulonephritis kid we had in the hospital about 5 weeks ago, this was a 5-year-old whose blood pressure was 160 over 120. So they are very, very at risk for malignant hypertension, and that usually can precipitate in the risk of seizures at the same time. Renal failure is common, and pulmonary edema is common. So most patients with nephrotic syndrome is not associated with hypertension, but 70 to 80% of patients with glomerulonephritis are associated with hypertension. Most patients with nephrotic syndrome do not have pulmonary edema, but 60% of patients with glomerulonephritis have pulmonary edema. So my style of practice, primarily because I'm old and can't hear very well, is I get a chest X-ray on any child that I'm worried about on nephrotic syndrome. I'm sorry, on glomerulonephritis, because I want to know if their heart's big or small. I want to know if they've got fluid in the gutters. I want to know if they've got any sort of extra fluid on board. So that it gives me a better sense of their volume status. Nephrotics are intravascular volume depleted. Glomerulonephritis patients are intravascular volume excess. So quite a difference between these two. Next slide, please. So Again, the workup is relatively straightforward. I cannot stress enough a physical exam and a blood pressure. Blood pressure really decides the urgency of how we have to respond to patients. The blood work done on nephrotics and glomerulonephritis patients are very similar, and we'll talk about complement as a decision-making in a minute. But the C3 is low. If C3 is normal, then a biopsy is going to be indicated. We'll talk about hypocomplementemia in a minute. Next slide. So we are fortunate here, and I've seen your guys' labs too. You guys have a fantastic lab there, but we get a C3 and a C4 of these children right at the beginning. So if you look at glomerulonephritis, often it's discriminated based on complement. And this low C3, there's three things that cause the low C3. It used to be called acute glomerulonephritis. Then it used to be called post-strep glomerulonephritis. Now it's called post-infectious glomerulonephritis. And the reason it's now called post-infectious is not because strep is not a cause, but strep is not the number one cause. And so the word post-infectious is now more appropriate. And so those of you who need to take boards in the future, you'll probably see the word post-infectious. Those patients have a normal C4. Lupus, which we see a new lupus patient here about every 3 to 4 weeks. It's amazing. Lupus is classically a teenage girl disease. We'll talk about lupus specifically in a minute, but those patients have low C3 and low C4. MPGN, which was renamed C3 nephropathy about a half a dozen years ago, can either have a normal or a low C4. So it's not as easy to know that, but MPGN is typically a young teenager disease, and post-infectious are often a child less than 10 years of age. Normal complements are everything else. The Wegener's, which are now called ANCA disease, IgA, HSP, membranous, all the whole gamut here. And so we use the complement very quickly to decide where we need to go with these kids. Next slide, please. Next slide, please. So epidemiology of classic hypocomplementemic or post-infectious GN, it does occur after pharyngitis. We see them in clusters. We actually have seen 5 in the last 5 weeks. That's not unusual. Next slide, please. They can be strep, but I've seen kids with influenza, mom syndrome virus, and with the ubiquitous year-round viral season we're now having at every institution in the country, we're seeing more of this related to influenza. Next slide, please. So again, grossly bloody urine, edema, headache, vomiting, seizures, but it's all related to the seizures are mostly related to hypertension. Next slide, please. I cannot stress the blood pressure enough. Next slide, please. And again, the classic workup is looking for renal insufficiency. What kills nephrotics is infection and clotting. What kills glomerulonephritis is that related to kidney failure. Next slide, please. Management straightforward, treat the hypertension. Diuretics are part of it, sodium restriction like before. Renal biopsies have indicated, dialysis have indicated. And so it's a whole gamut. And I also always tell people that the kid's a lot smarter than I am. We're going to let them decide where this is going to go. Next slide, please. If you look at most kids with post-infections, the vast majority resolve. They usually have proteinuria or hypertension for the first 3, maybe 4 weeks. It resolves. They may have microscopic hematuria for 1 or 2 years. So it's not surprising that these kids will have hematuria for a while. Next slide, please. Most of these kids do fine. If their complement does not normalize in 8 to 10 weeks after presentation, then often a biopsy is ordered because of persistent hypocomplementemia. But the classic scenario of hypocomplementemic glomerulonephritis due to post-infectious is the complement resolves on its own with no intervention, no steroids within about 6 or 8 weeks. Next slide. All right. I cannot stress enough of this, guys. I know this is a crazy picture, but it gets your attention. Next slide, please. So I want to talk about glomerulonephritis associated with skin rashes. And we've all seen this. And often the skin rash is a leukocytoclastic vasculitis. And we see skin rashes with glomerulonephritis associated with hinoxalin purpura, with lupus, with Wegener's, as well as allergic drug-induced. Next slide, please. This is a skin biopsy, that right in the middle where you see the very dark area, that's called a nuclear debris, which is actually a breakdown of cells. And this is called a leukocytic classic vasculitis. And this is what you'll see. It's not pathognomonic of any one disease other than leukocytic classic vasculitis. If you do if you do immunofluorescence on that, and there's IgA staining, it could be HSP, but also could be lupus. So again, not diagnostic. Next slide, please. Pulmonary renal syndromes are fascinating. We picked up 2 in the last 6 months. These are the kids that come in with hemoptysis and glomerulonephritis at the same time. The big 4 are Wegener's, anti-GBM disease, also called Goodpasture disease, lupus, and Church-Strauss. Now, remember that if you look at those, the only one that has complement abnormality there is lupus. The other 3, which is Wegener's, anti-GBM, and Church-Strauss, are all normal complementemic. So I've seen a number of kids in my life with pulmonary hemorrhage. The day that the towers were hit, I was at a hospital in an ICU. A young lady had literally coughed up a liter of blood in 1 hour. You give them a gram of Ciamedrol and they respond very, very quickly. I've also seen kids go on ECMO with this disease. So it can be really devastating. Next slide, please. So think about labs that we do, and I'm going to tell you about labs that are helpful but not helpful. So if you've got a child with glomerulonephritis, it's never wrong to get an ANA, but don't hang your hat on it because there's 30% incidence of positivity in school-age children with ANA. It's never wrong to get an ASO. It's not wrong to check it, but don't hang your hat on it because 50 to 60% of children in school have a positive ASO. And ANCA is an interesting test. We all talk about getting ANCAs all the time. I can return over kidney biopsy in 24 hours, but our ANCA here takes about 4 days. But ANCA is only positive in 50% of children with Wegener's, but it's also positive in lupus and HSP. So again, not specific, not wrong to get it. Don't hang your hat on it. Next slide, please. If you look at biopsies, which we like to do, the left upper one is a normal looking kidney. The right upper one is mild mesangial proliferation, that's the dark pink. The left lower one, number 3, is, you see that it changes in the lower part of the slide. That's called focal sclerosis, and the one on the right is called MPGN. These are various biopsies you'll see on light microscopy. Next slide, please. This is a membranous lesion. On the left is the light, on the right is the electron microscopy, and you've got very thick. And on the right slide, on the right picture there, you'll see intraglomerular based membrane deposition. That's a membranous lesion. Next slide, please. So immunofluorescence is where the money is on a biopsy. So immunofluorescence is you take a piece of tissue, kidney tissue in this case, you stain it with IgG, A, MC3, C4, C1q, and you notice that the post-infectious is typically IgG positivity. Lupus is positive for everything. On the far right, Wegener's is never negative for everything. The other name for Wegener's histologically is called pauci-immune. If you look at HSP and IgA, they both have IgA deposition. In fact, the number of patients who we see with IgA and HSP, if you put their biopsies side by side, they're identical. MPGN is also called C3 nephropathy, and membranous is deposition of IgG in the basement membrane. So the money on a biopsy is in the IF pattern. Next slide, please. Let's talk about specific summit glomerulonephritis. We're seeing another increased uptick in HSP right now. Next slide, please. This is classically what we know. It's typically a child usually less than 7 years of age, cramping abdominal pain, maybe some arthralgias, arthritis, the purple spots of the legs, and no fevers. Next slide, please. Often their normal blood pressure, their exam is not impressive. They can't have localized edema at the level of the lower legs at the same time of the purpuric rash. Next slide, please. So this is a typical purpuric rash, but I can see that same rash in Wegener's. I can see that same rash in lupus. I can see that same rash in Church-Strauss. So it's not 100% diagnostic. Next slide, please. So what's the differential? What is the workup? What is the short and term outcome? Next slide, please. So it's an interesting question. So often these kids, I always talk about if you've got multiple organ involvement, in this case, skin, joint, and abdomen, that's a systemic vasculitis. It could be immunologic, it could be infectious, and rarely could be malignant. There are some causes that are infectious, which we don't see that very often, but the immunologic causes are what is listed below. PAN is polyarteritis nodosum. Next slide, please. So what we need to do is rule out any other changes. We need to rule out certain things like Wegener's, lupus. That's why we get blood work and complements. Next slide, please. Age of onset of HSP, also used to be called anaphylactoid purpura, is often they're less than 10 years of age. 100% of these kids have rashes, 60% have arthritis. Abdominal pain vasculitis is 70%. With either gut edema or purpura or intussusception. There are a number of pediatric surgery case reports of patients who went to the OR to getting a lap for appendectomy who had no systemic rash. And they open up their belly and they saw purpuric lesions on the serosa of the abdomen. They closed back up the belly because the child did not have appendicitis. And what they did have at that point in time was the rash from the skin. Renal involvement's about 80%. Next slide, please. So the treatment for the rashes is supported. A lot of people give steroids. Probably there's no harm, but there's not a lot of good evidence that makes a hill of beans difference. What I do tell the family, though, that there's a recurrence rate of 50% of the rash within 3 months, because the families get pretty concerned about that. Next slide, please. Joints, NSAIDs are always the benefit. There's no role for steroids. Usually the resolution is relatively quickly, 4 to 6 weeks, often quicker than that. Next slide, please. There is an interesting paper that was an old paper that looked at the use of steroids in non-intussusception abdominal pain. And it pointed out that those patients who got steroids had a shorter length of stay in the hospital and had a quicker resolution of their abdominal pain. So that may be the one area that steroids have a benefit. But beware, especially if you're throwing NSAIDs on the patients, that you may have GI distress. So H2 blockers or PPIs may be in order in combination with everything else. Next slide. So renal involvement is hematuria alone, 40%, glomerulonephritis is 60%, hypertension. And we've seen kids with kidney failure and nephrotic range proteinuria. Often those kids get biopsied. Next slide. So the question of what to do with the renal involvement, and it's controversial. Clearly, we treat the hypertension. If there's renal insufficiency, we're going to biopsy them. But there's never been a controlled study that says steroids are positive or negative. I have tendency as a style of practice to give these kids steroids if they've got renal involvement, but I do it after biopsy. Next slide, please. Treatment of steroids. There's kids who have recurrent abdominal pain, often really do well with like a 6-month course of azathioprine. Cyclophosphamide or Cytoxan has been used, and again, ACE and ARBs have been used for chronic proteinuria. Next slide. Long term, though, there's emerging nephrology literature, and this is an old slide, I apologize for that, but 10 to 15% of kids with HSP develop chronic kidney failure. So that brings up the question, should they have been treated up front? And that data is never going to be identified 100%. But just be aware that these children may have chronic proteinuria, chronic hypertension, and probably need to be vetted through a nephrologist at some point in time. Next slide, please. Let's go to lupus. Lupus is a fascinating disease. It is often presents in teenagers, often teenager females, and there is a biopsy in lupus of the kidney that's discriminated, what's called the World Health or the WHO classification, discriminated by light microscopy. Next slide, please. So it's often in females. It's typically almost a 5-to-1 presentation. It's common in kids between 11 and about 15 years of age. And so if we have a teenage girl that shows up with glomerulonephritis, they get compliments automatically because we just assume they've got lupus until proven otherwise. Hypertension is common. Renal insufficiency is common. Next slide, please. So again, the routine workup, physical exam, blood pressure, complements, ANA is not specific. We talked about that. Then you go get all the anti-DNA, anti-Smith-Rowan law, anti-cardiolipin antibodies, anti-thyroid antibodies. In our hospital, those take 3 to 5 days. Turnaround time, complements come back in 2 hours, biopsy comes back in 24 hours. So we have a tendency to biopsy at the very early portion here and then wait for all the other antis to come back. Next slide, please. Lupus can have hematuria alone, proteinuria alone, nephrotic syndrome, kidney failure, and also pulmonary renal syndrome at the same time. Next slide, please. The WHO classification was developed the same year I graduated from high school. Thank you very much. And it's actually helps discriminate some of the therapy in these patients. Next slide, please. So classically with WHO 3, 4, and 5, which is focal sclerosis, type 4 is called diffuse proliferative fibrous membranous. Often cyclophosphamide is part of the therapy. Sometimes CellCept, which we'll talk about in a minute. And these kids often will get 3 to 6 months of steroids along with cyclophosphamide. Next slide, please. Cyclophosphamide, as mentioned, we often will give a monthly escalating dose. We start at about 500 milligrams per meter squared and move up to 1,000 milligrams per meter squared on the third monthly dosing for 6 months duration. There's some really nice NIH studies done in the 80s and early 90s that show that IV cyclophosphamide is superior to azathioprine in combination with steroids in order to have resolution of the renal involvement. Remember, what kills patients with lupus is infections and renal failure. Therefore, we need to be very aggressive with the renal support right up front. Next slide, please. This is the short-term versus long-term. Short-term of Cytoxan versus long-term is the 3 to 6 month variation. And clearly, if you look at remission rates, patients with a 6 month course of Cytoxan, or even further than that, have a much better prognosis from a nephrologic perspective. Next slide, please. So there's been some interesting adult studies and never been a pediatric study, and I'll explain why in a minute. But adults were randomized based on WHO classification 4, which is diffuse proliferative, of steroids and CellCept versus steroids and Cytoxan, or steroids and azathioprine. And as for the most part, the CellCept and the Cytoxan looked identical to each other. Unfortunately, about 20% of patients on the CellCept side did not respond, and therefore they got moved over to cyclophosphamide. I was in Mexico City a number of years ago giving a talk on lupus, and we talked about what gets done in Mexico City. Lupus is the same no matter where you are in the world. They do not use CellCept in their pediatric population because the cost is prohibitive, but the cost of cyclophosphamide is cheap. There never has been a controlled prospective study in children that looks at these two in comparison. What our style of practice is often give 6 months, I apologize, of cyclophosphamide, then move the kids over to CellCept. The problem is that these kids are teenagers, and teenagers have never known to study that the pills are much more effective when they leave the bottle and go in the mouth. And so if you look at a classic teenager who's going to be on 2 pills twice a day of CellCept for a month, that's about 120 pills versus 1 dose of IV Cytoxan a month. Compliance has to be played into this. Next slide, please. So pheresis has very little role and IVIG has very little role. Next slide, please. Prognostic factor in this and all glomerulonephritis is the same. If you've got a high creatinine, if you've got chronicity on your biopsy, if you're anemic, you've got a high chance of going on to end-stage renal disease. We've transplanted in the last 2 years 2 kids who we were unable to rescue from lupus, who now have been successfully transplanted. Next slide, please. Complements should normalize with steroids. Anti-DNA should normalize with anti-proliferative agents such as Cytoxan, and the proteinuria should resolve. Next slide, please. Let's go to Wegener's, and this will be my last section. Wegener's, again, pulmonary renal syndrome patients. The ANCA may or may not be specific. And again, it can be positive in HSP and lupus. Next slide, please. Wegener's is actually often overlapping what's called percentic glomerulonephritis. And this is a biopsy on a patient. There's two arrows here. The big yellow arrow points out a crescent. That's called crescentic glomerulonephritis. And the small arrow on the left that points to the higher pink is to necrosis. So these are necrotizing glomerulonephritis. It's not 100% diagnostic of Wegener's, but it's usually diagnostic of Wegener's. Again, if you look at the immunofluorescence on these patients, the immunofluorescence is often negative, so it's called quasi-immune. But if we see a crescentic glomerulonephritis, we know that patient's going to be in trouble. Next slide, please. So if you look at comparison of HSP versus lupus versus Wegener's, all three have skin involvement, all three have joint involvement, all three have glomerulonephritis. That's why these things overlap a little bit. Again, complements are normal in HSP and Wegener's, are low in lupus. Anti-DNA is negative in HSP and Wegener's, but positive in lupus. ANA may be positive in all three, and anti-DNA may be positive all three. I'm sorry, I apologize. ANA can be positive all three, and the ANCA can be all positive all three. So that's the problem. But so the complements actually are really helpful right up front. Next slide, please. So I brought up vasculitis because vasculitis and glomerulonephritis are very common, and we see them in consort. So we see a lot of kids with glomerulonephritis. We're fortunate to have the skill set to go to a biopsy pretty quickly, and that helps us a lot. Next slide, please. So in conclusion, nephrotic syndrome, most of those kids do fine. Biopsy gets done if they don't act right, if they've got renal insufficiency. Glomerulonephritis patients, we biopsy patients who are normal complementemic or do not, their complement does not normalize. But there is a lot of overlap between these two, and frankly, the literature is very difficult in these two. I'm going to end there, and I'm going to offer the students and the residents in the room, and I've talked to your program chairman about this. We are happy to be a resource for your education. We're also happy to have you rotate with us, and we could figure out how to work out those details. We see 60 to 90 outpatients a week in nephrology. We see another 30 to 40 outpatients a week in rheumatology. We run in about 10 to 15 kids in house every day on nephrology service. So we have a fun service. We have a lot of fun what we're doing. And any of those who want to rotate with us, give me a call or send me an email. With that, if we can figure out how to communicate, I'm glad to take any questions.
Can you hear us?
We're not muted. You should be able to.
Dr. Bunchman, are you hearing us? That's not fair.
He cannot hear.
I think the folks online are hearing us. We may need to type in the chat. You may ask questions now.
I'm sorry, I apologize. I had my sound turned down. Let's try that again. I can run a dialysis machine, doggone it. These Zoom meetings are just hard for me.
Dr. Bunchman, I had a question about lupus nephritis. Many of these patients with cutaneous lupus are on hydroxychloroquine. Is that any helpful in lupus nephritis?
The answer is who knows, right? We use Plaquenil or hydroxychloroquine in every patient with lupus, period. Hydroxychloroquine probably has a benefit of allowing us to reduce the steroids on patients. That's helpful, but there's no direct evidence that is a direct benefit on the kidneys themselves. It's more of an adjunct. So our typical lupus patients are on, from a maintenance perspective, are on low to no steroids if we can avoid it, because teenagers don't like steroids. MMF, which is mycophenolate mofetil or Celsep, along with Plaquenil, which is hydroxychloroquine. And often we use a lot of calcium channel blockers, such as amlodipine, because these children often have a component of Raynaud's that actually may be benefit.
Thank you. In patients with nephrotic syndrome, at what point do you consider starting statin if they have persistent hyperlipidemia?
It's a really good question. There's a really cool study that was done, 20 years ago that looked at people my age, actually younger than me, because I'm pushing 70 right now, guys. But looking at people in the 50s and 60 years of age that actually had classic childhood nephrotic syndrome with resolution. And these patients had coronary angiograms because we know that when they were children, they had cholesterols of 400 to 600, but they had resolution. It turns out that the coronary arteries of people that had nephrotic syndrome 20, 30, 40 years earlier had no higher incidence of plaques, which is great. So we only use statins if there's steroid resistance, because as you treat the nephrotic syndrome and as the nephrotic syndrome goes into remission, the production of lipids and triglycerides go down, and then that resolves. So we do not use that as a primary adjunct, only in steroid resistance.
Thank you.
Guys, I do apologize for my inability to figure out how to use this technology. I'm just an idiot most days. So I hope you like the beer slide, though. It's one of my favorite slides. I put my email in the chat. Again, I'm not saying you have to talk to me, but I'm pretty available, and I'm happy, and I love. If I were just doing clinical care 24 hours a day, I'd be happier as a pig in slop, guys, because that's what I love doing. I'm on call right now and wiping on this talk. I've had 2 pages already, but that's what I do. But patient care is a blast, and I'm available on my phone, which I put there at the very beginning. And Megan's got my slide set, and I'm available on my email pretty much 24 hours a day, unless I'm on an airplane. Any other?
Dr. Bunchman,
Go ahead.
this is Chris Pierce. We'd had a conversation a while back talking about this, and I'm glad we've gotten some fruition of getting you involved with some of the education down here. Really just enjoyed the talk. Just want to say we really appreciate you doing this for us. A little bit of a technical difficulties helped us fill the room a little better down here. So we actually appreciate that.
Well, I am offering what I've offered before. Megan or I are happy to set up even once a month education talks for the house staff. We do this all the time. I probably need to figure out how to use this crazy technical stuff, but we're happy to be a resource of education, because in the long run, that's all of our attending's job is to be educators.
Amen.
Any other questions, guys? Okay. I appreciate it.
Thank you.
Bye-bye.